lesion preparation in severe calcified lesion is essential for successful stent delivery, adequate stent expansion, prevention of stent thrombosis and restenosis. I think most of the people in the room and on the panel will agree to this statement. We have several options and several tools for lesion preparation in severe calcification, either balloon-based or as atherectomy debulking devices. And there's only few randomized data on differential usage of these lesion preparation options. There is the earlier ROTAXUS trial, which compared a standard balloon approach followed by the TAXUS stent with rotablation followed by the TAXUS stent. And there's the more recent PREPARE-CALC trial, which used modified balloons. That means cutting scoring balloons upfront prior to a new generation DS, and randomized this to rotablation plus the new generation DS. And my objective for this presentation is to compare the ROTAXUS and the PREPARE-CALC data regarding baseline characteristics, strategy success, acute lumen gain and late lumen loss at 9 months, as well as regarding target lesion revascularization at 9 months and peri-procedural complications. There are other analyses ongoing. As you see, the baseline characteristics of both studies are clearly different, and patients get older in PREPARE-CALC, and lesions become more complex in PREPARE-CALC. The strategy success was significantly higher with a rotablation in both trials, and rota was required for a successful procedure in up to 20% of the cases. And this superior strategy success of rota was consistent in both studies. The superior strategy success in PREPARE-CALC was mainly driven by a much higher crossover rate. 16 patients had to cross over to rotablation, and this was due to non-crossable lesions which could not be crossed by the balloons or by the stent or by inadequate dilatation of the stents, of the lesions. The mean acute lumen gain is shown on this picture, and acute lumen gain is best with rota or modified balloons. The acute lumen gain generally improved in PREPARE-CALC compared to ROTAXUS. We had no excessive instant late lumen loss with rota in PREPARE-CALC, and this was clearly different to the results of the ROTAXUS trial, where we had this 0.44 late lumen loss with rota and TAXUS. And instant late lumen loss at 9 months is generally lower with modern DS. The clinical outcome was excellent in PREPARE-CALC, 1-digit target lesion revascularizations, which is clearly lower than in the previous ROTAXUS trial. And it appears that the clinical benefit of modern DS is more pronounced if we have rotablation upfront. This is the analysis of the peri-procedural complications, and therefore we pooled the data in 600 lesions. And what you see is that we have more dissections, not surprisingly, with modified balloons. Other complications are comparable and low. Now, how to decide on the upfront strategy? which patient clearly needs a rotablation. We have no clear answer to that, but the subgroup analysis of PREPARE-CALC might give us some answers. There was an interaction in favor of rota for males, non-LAD lesions, and type C lesions. What about the intravascular imaging? It is the goal of the PREPARE-CALC OCT trial to address this question, and this study will be presented in the afternoon in the late breaking trials session. If you are interested, you should join this session and look at the results. All what I can say right now, everything depends on the fact whether you can get your intravascular imaging in place. Here are my conclusions. In patients with severely calcified coronary lesions, elective rotablation is feasible in nearly all patients, and the acute success rate is superior to any balloon-based strategy. Acute lumen gain can be improved with cutting and scoring balloons. Use of rota is no longer associated with excessive late lumen loss in the era of modern DES. As both approaches, either the elective rotablation or a balloon plus bailout rotablation, are equally safe and effective, we have to establish criteria for the optimal upfront strategy, and this is possibly dependent on intravascular imaging, as we have seen in the case right now. And finally, contemporary rotablation and modern DES provide excellent acute and at least midterm results in more and more complex PCI scenarios. Thank you very much.